Yeah, it was absolutely wild. And I remember I was thinking about that case for months. It is the season 2 finale of the Pitt, and everyone is crashing out, and there are so many loose ends that need to be tied up in this one last episode, and I have no idea what to expect. I'm Dr. Jeff, a board-certified ER doctor in the USA and Canada, and I'm also a clinical assistant professor at the University of British Columbia's medical school. So I'm going to be your guide. I'll go over what's realistic, what's not, and I'll guide you through all the medical management throughout the show. Let's get to it.
We got a dead body. He was a DNR.
What was his chief complaint?
Hemorrhoids and constipation.
Holy shit. So a patient in their waiting room died. Apparently he checked in at 5 a.m. and was waiting to be seen straight through to, I don't know how late it is, like 9 p.m. now. And essentially was found dead in the waiting room. This would 100% make headlines on the news. I think if this happened anywhere, for someone to wait that long for care, even with just like mild, with constipation, that is an unacceptable wait time. I've spoke about this before on previous Pitt reviews, but the longer patients wait in the waiting room, the higher risk that they are for complications, like, you know, their medical condition to evolve and get worse, or for patients to die. So this is a critical incident that would need to be investigated by the hospital.
He was alive and kicking when my shift ended this morning. This is definitely a day shift patient.
One of the biggest problems in healthcare right now is that a lot of people don't have access to a family doctor or a specialist to manage their health concerns. And what that means is they end up going to urgent care or the emergency room, waiting for hours in a crowded waiting room surrounded by people who are coughing, vomiting, or really sick for something that could have been handled much more easily in a clinic or over a video call. On one end of the spectrum, these are things like viral illnesses like the flu, sore throats, or coughs. Things that are uncomfortable but usually don't need emergency care. But on the other end, it's conditions that should have been caught earlier, like uncontrolled high blood pressure or diabetes. These don't cause symptoms early on, but over time, they can lead to other problems like strokes, heart attacks, or kidney failure. And that's where ZocDoc comes in, who sponsored this video. ZocDoc makes it way easier to find and book a doctor. You can search for local in-network providers, compare options, read real patient reviews, and see detailed profiles all in one place. They've got over 150,000 providers across 200 specialties, and you can actually see real-time availability and instantly book an appointment. Most visits happen within 24 to 72 hours, and sometimes even the same day. And the best part is that it's completely free to use. Finding the right doctor who listens and partners with you is often the first and most important step in getting the care that you need to optimize your health. If you've been putting off a health concern, this is a really easy way to take that first step and deal with it early before it turns into something that lands you in the ER. Head to ZocDoc.com/Dr. Jeff or click the link in the description to get started and book your appointment today. Okay, back to the episode.
This dude dead?
Nope.
Crazy. Dude, that would be so traumatizing for patients in the waiting room to see someone dead. I think they're probably handling it in the correct way to provide patients with reassurance that he's not dead, and then to transport him into a more private space where they can actually like do a formal assessment, formally declare death, and then like, you know, do all the aftercare. Yeah, that would be so stressful.
It began after a bad case of viral meningitis when I was 5.
Are you driving?
Been seizure-free. Cleared by neurology to drive and to work as an attending.
Typically, someone needs to be completely seizure-free for a 6-month period. They need to be compliant with all their medications. In this case, she's on Keppra, which is also known as levetiracetam, which is one of the most common anti-seizure medications that we prescribe people. And it sounds like she had all of her seizures under control for a long period of time. It sounds like her seizure frequency and severity are getting worse. So it might be that she needs to have her medications adjusted, but it also might be because the stressors are actually triggering her to get more seizures. We'll see.
How long between the seizure you had today and the last one?
Well over a year, but I had 2 today. I don't know why. Could be sleep deprivation, new job stress.
What are your options now?
Up my Keppra, a temporal lobectomy, get a neuromodulation device.
My first thoughts on the case of Dr. Al-Hashimi is Keppra or levetiracetam has worked in the past, and so I think the first line of management would be to actually increase the dose of Keppra to see if that actually helps to suppress her seizures. The other one would be to add on an additional anti-epileptic medication or to change it around. It would not be to go straight to a partial lobectomy or a neuromodulation device. Those are typically reserved for patients with severe epilepsy or seizures that are refractory to medications. If we've ruled out all the big, bad, scary things and all of the possible structural or metabolic or infectious causes, it may just be sleep deprivation or stressors that are actually causing these increased frequency and severity of seizures.
Need to disclose this.
I know.
Dr. Robbie is now in a tough predicament because he is kind of like the chief of this emergency department, and he has one of his staff that has a neurologic impairment that may actually place other patients and other staff members at risk. Someone who is having recurrent seizures is, first of all, not safe to operate heavy machinery or drive or swim, and they are definitely not safe to continue practicing as an emergency physician where other people's lives are in their hands.
We deal with the weirdest and the wildest because
we are the weirdest and the wildest of them all.
Tonight they're really gonna be crawling. Now go get some.
So this is really funny. So Dr. Abbott is calling his night team the night crawlers. Definitely there is a big difference between doctors and nurses that only work night shifts and doctors and nurses that only work day shifts. The vibes are completely different between the two, and I think people that only work night shifts, which is kind of like me, take pride in that because I think you just need to deal with a lot crazier shit with lower resources on the night shift. She looks tired AF. I feel her. You know, at the end of a 12 or 15-hour shift, your brain is completely cooked. And there's something that we often talk about in emergency medicine, which is decision-making fatigue. So you can kind of think of your ability to make decisions as a limited resource throughout the day. Every small decision, whether it's deciding what kind of coffee to drink, deciding what to make for breakfast, to more serious decisions like deciding what drugs to give a patient who's crashing, deciding who will go see what condition. All these different decisions that you make throughout the day are going to tap into that limited resource. And once you use most of those resources, essentially your brain switches from like 5G down to 3G, where everything is going to be much more effortful to think and make decisions. We try to delegate as many tasks and decisions to our team members as possible and keep our minds sharp for the decisions that really matter.
Abbott's an adrenaline junkie who gets shot at for fun. Robbie's got like PTSD or something. Wait,
Okay, I mean, I'd hate to know what you think about me.
I don't know. The more time I spend here, the more I realize the importance of like mental health.
Javadi is bringing up a really great point about the different personalities that exist in emergency medicine, and definitely there is a personality in emergency medicine. It's someone that has ADHD, adrenaline seeking, and I feel like those are the types of minds that thrive the best in this environment. But with that, there is a huge toll on your psyche and your emotions because you're just exposed to so much crazy stuff all the time.
I wanted to let you know I've been checking out some of your online
Look, I was
posts.
just trying to help get some health messages out there, especially
I
for
think they're
young
great.
people.
As long as you follow the HIPAA laws.
It's really great that Dr. Robbie is supportive of Javadi's social media posts. I do really wonder if they're actually going to show us some of her posts because I'm just kind of curious, you know?
Actually, Dr. Robbie, sorry. Can I ask you a question? I may be considering emergency psychiatry.
I think that you can do anything that you put your mind to, Victoria.
There's a funny reaction from Dr. Robbie. It seemed like he was kind of taken aback. I think it probably stems from him wanting her to go into emergency medicine because sometimes when we do see a medical student that's like, you know, got the nerves, got the skills, got the knowledge base to be an excellent emergency physician, it is kind of like, it hurts a little bit when you hear that they want to go into something else.
Life can be challenging, especially when it doesn't work out the way you expected.
Okay. It's never too late.
Do you really believe that?
So it looks like Samira Mohan is not going to be continuing her path in emergency medicine and is going to pursue something else like geriatrics. Dr. Robbie, as the attending, does have a duty to tell his learners when he thinks that they're in the wrong profession. I've had some learners that just really struggled, and I've had to have some like pretty serious conversations with them as well. It's never out of malice. It's not because I'm trying to like bully them or anything like that. It's just, you know, working in an academic center and working with so many learners over the years, you do really get a keen sense of like who will be able to deal with the stressors of the emergency department and who might crack under the pressure. So those are my thoughts.
When people worry about you, it makes me think that I should be worried about you, and I don't like worrying about things.
I'm not the one who spends his free time getting shot at.
I feel like with any kind of conversation, you can only meet someone where they're at. In medicine, we often talk about the stages of change, those being pre-contemplation, contemplation, preparation, action, maintenance. These are the stages that we kind of assess where a patient is in getting better from whatever condition that they're suffering from. Dr. Robbie seems to be in the pre-contemplative stage where he's not really willing to engage or talk about the mental health or suicidality issues that he's having.
I'll come back for all this other shit.
Great.
If you promise to come back and let me take the Bonnie for a ride.
I'll think about it.
Damn. This is a major red flag. Dr. Robbie's friend is asking him to essentially give him a contract for safety, tell him that he guarantees that he will return safely, and Robbie won't even contract for safety. So if I was having this conversation with him as a healthcare worker, I might actually involuntarily commit Dr. Robbie and get him seen by psychiatry. That's how serious this is.
36 weeks pregnant with 2 days of headache. Now a 10 out of 10 with blurred vision. BP 174/120, heart rate 92.
When Dr. Robbie pressed on her ankles and you see some denting of the skin, that is what we call pitting edema. That often means that there's essentially leaking of fluids out into spaces where they shouldn't be, like in the ankles and in the abdomen. So she's 36 weeks pregnant and at full-term pregnancy, and she's coming in with headache, vision changes, and high blood pressure. This is what we would call preeclampsia until proven otherwise. This is a severe condition where essentially the patient and the baby are going to be at high risk of seizures and death. We would be looking for something called HELP syndrome. So HELP syndrome stands for hemolysis, elevated liver enzymes, and low platelets. This is one of the most severe forms of preeclampsia, eclampsia, and essentially the real management would be to deliver the baby emergently because both the patient and the baby are going to be at risk of death.
Pitting edema, severe preeclampsia.
Yeah.
Where are you doing your prenatal care?
Nowhere. It's a wild pregnancy. I want a free birth.
She says that she's not getting any prenatal care. We are seeing this way, way more frequently. Women that want to have at-home births, they don't want any prenatal screening, including ultrasounds or blood work or anything like that. And that definitely puts both the patient and the baby at high risk of complications during the birth.
Well, it's a wild pregnancy, so that means no medical care.
Then why are you here?
I just need to get rid of this headache.
One thing that I do want to touch on is just the overall trend against medicalization for, you know, various things, whether it's pregnancy and delivery or just like any other ailments throughout your body. I hear all the time, oh, you know, like I'm all natural, I don't want to take medications. You know, if you're sick with the flu, I don't want to take Tylenol and Advil because I don't want to take pills. I agree with the sentiment that we should not be giving patients medications and procedures unless they absolutely need it. If we can address issues with lifestyle modification or with natural means, that is great, but there are many instances where really the safest thing to do is giving medications and taking patients for surgery, and this is one of those instances.
No. Ultrasound can harm the baby.
Not true.
Not doing the ultrasound could end up harming you and the baby.
Women have been having children on their own for thousands of years.
Yeah, with an infant mortality rate of 30% for most of those thousands of years. At 37 weeks, the cure for preeclampsia is to deliver the baby. We need to get you upstairs so the OB doctors can induce labor to save you and your baby.
No.
One of the things that I really do believe in is patient-centered care, like allowing people to make their own decisions for their own selves and their own families. But people really need to understand the risks involved in the decisions that they're making, because I think the information that is given to people on the internet through various influencers and people that have incentives that are pushing these narratives is that it's a very one-sided conversation. There's not much nuance to it. There's a lot of like sound bites that kind of are meant to provoke people or kind of elicit an emotional response and make people afraid of, you know, receiving a vaccine or receiving different, medical care for various things, and they're meant to paint doctors and healthcare in this like negative light where we're like collaborating with big pharma and trying to keep people sick so that we're making money off of them. But really, like, I think the vast majority of doctors, nurses, different healthcare workers are in this profession because we want to help the ill and we want to like make sure that people can live healthy, happy, long lives. When someone has internalized these views that they do not want any kind of medical care and they want an all-natural birth, and they actually like form their identity around this, it becomes really hard to actually meet patients and find an appropriate compromise where they still feel like their values are being honored and we are able to provide the safest medical care. I think that she probably does have HELP syndrome, so this is a true obstetric emergency and the patient would need to deliver that baby immediately, either through induction or cesarean section.
HELP syndrome.
Hemolytic anemia, elevated
that.
liver enzymes, and low platelets.
Oh, she's seizing.
She's seizing. So now she's got
10 of
eclampsia.
IV diazepam, have another 10 ready. Hold intubation, let's try to break this. We don't want to mask seizures with paralysis unless we have to.
Oftentimes if you paralyze someone to actually put the tube in, people can still be seizing and you wouldn't be able to detect it. That's one of the reasons why we wouldn't jump to paralyzing and intubating someone. The other thing that I want to mention is the fetal heart rate is starting to drop at 90 beats per minute. This is one sign of fetal distress. So if they aren't able to rapidly treat the seizure and resuscitate this patient in a way where the fetal heart rate comes up, that would be one indication to perform an emergency C-section in the emergency department.
Pulse ox is 88.
Dr. Abbott, intubate.
Let's do it.
Propofol for the anti-seizure effect. Sucks to avoid prolonged paralysis so we can check a neural exam.
This is totally correct. They chose the correct medications for intubation using propofol. This is the medication that Michael Jackson was actually using to help fall asleep. It's a fast-acting medication that also causes what we call burst suppression of seizures. Patients with severe status epilepticus, which means ongoing severe seizures, we would give really large doses of propofol to actually suppress the seizures. Succinylcholine is a short-acting paralytic, which only lasts about 10 to 15 minutes. So the reason that we would choose that medication is because once the paralytic wears off, we would actually be able to see if there's any convulsive behavior so that we know to up-titrate the anti-seizure medications.
Good, lung sliding bilaterally.
Roll to the left again, that can help.
So they just put EEG monitors on the head. This is not something that any emergency staff are trained to do. I've personally never placed any EEG leads on someone's scalp. I don't think any emergency nurses have either. This is something that only a neurologist or the epileptology team would actually do, but this is not something that like the resuscitation team would be involved in at all.
Still seizing while paralyzed. It's non-convulsive status.
They confirm that the patient is still having seizures, or what we call subclinical seizures, or non-convulsive status epilepticus, after the patient has been intubated. Again, it's because the patient is now paralyzed and can actually show signs of the convulsions. Because the patient now has EEG monitors on that show that she's still seizing, this is a clear indication that they need to go higher and higher on the anti-epileptic medications. So typically what I would be doing is considering doing phenobarbital or just giving her massive amounts of propofol. In this case scenario, we would have had both obstetrics and neonatology there in the ER like way earlier. Typically what I would be doing is I would be dividing this team into the team that's taking care of the baby and the team that's taking care of the mother and getting set up for an emergency C-section. Fetal heart rate is still quite low. This would be a clear indication that they actually do have to do an emergency C-section. They should not wait for the patient's seizure to break because the longer that they leave the baby inside, the higher the risk there is to both the baby and the patient for death and severe neurologic compromise.
VFib.
Chest compressions nasally, charge to 200.
Emilie, what's the 4-minute rule?
I'm not sure.
4-minute rule is the time that they need to perform a perimortem C-section from the time that the patient goes into arrest. So they're preparing to do what we call a perimortem C-section. And if you don't deliver the baby within 4 minutes, the baby is at really high risk of death. So from the time that you make that decision that you have to do the C-section to the point that the baby actually exits the belly, You got 4 minutes to do that, which is like incredibly stressful. And I feel like they should have delivered the baby long before this even happened. So yeah.
First incision is from the xiphoid to the pubic symphysis,
through the skin to the linea alba.
In this procedure, they are depicting this correctly. So you get a 10-blade scalpel, make an incision, vertical incision from the sternum down to the pubic symphysis, essentially from here down to here, straight down, and you're cutting through all the different layers, so through the abdominal wall, through the peritoneum to gain access to the abdominal cavity. And then once you identify the uterus, you would then have one person that's designated to actually retract the bladder as well, because the bladder can actually kind of be up there and blocking the uterus. So you move that out of the way so that you're not actually like cutting into the bladder and causing injury to that. Then you would make a lower incision on the actual uterus to deliver the baby out. The first glimpse of the baby makes it look like the baby is floppy and purple. We would then assess Apgar scores, which are essentially scores that tell us how sick a baby is when they are first delivered. Blue and floppy baby that is not crying, that is very, very concerning. First things that we often do is we dry the baby down, flick their feet, and try to stimulate the baby to see if they wake up and start to breathe and cry. And we put them in the warmer as well.
Removing the placenta.
It's intact?
Yeah.
Okay, so they just delivered the placenta. That actually looks like a real placenta. So I wonder if they actually got a real placenta from a real patient, because I feel like it would be hard to replicate that in real life. That looks very, very legit.
We Pitocin to contract the uterus.
And lots of massage.
Now they're giving oxytocin, which helps the uterus to contract down so that you don't get postpartum hemorrhage, severe life-threatening bleeding from the uterus if it stays kind of flaccid. So you want that uterus to contract down as you sew it up so that it stops bleeding.
At 1 minute, she's 0 for color.
What McKay is doing is slapping the foot of the baby. That is what I was referring to earlier. Typically, we'll flick the bottom of the feet to try to stimulate the baby.
Apgar 5.
Apgar scores are rated on a scale of 0 to 10. A is for activity, like whether they're actually moving all 4 limbs, and R is for respiration, whether they're breathing or not. So a score of 5 puts them in that mid-range, and they would have to continue resuscitating this baby until their Apgars are 9 or 10.
Looks like sinus. And I got a weak carotid.
Okay, cycle the BP.
Emilie, the Apgar.
With hypoxia, total of 7.
Respiration scores for observed breathing, not pulse ox.
With no crying, she still gets 1 off.
They now got the mother in normal sinus rhythm. They saved the mother's life, and it looks like the Apgar scores are actually starting to come up for babies. So baby is actually doing much better. I still find it a little bit hard to believe that both obstetrics and neonatology are nowhere to be seen. Even like the obstetrics nurse that was previously involved in actually doing the fetal monitoring before the patient seized, I don't even see her around, which is like kind of unbelievable.
What did I miss?
Eclampsia with status HELP syndrome.
Septic twin C-section. Got your text 12 minutes ago.
Shit happens fast down here. Resuscitate.
So they explained it that the obstetrician was upstairs doing a C-section for a twin delivery, which is why they couldn't come down. But yeah, crazy. That is a crazy ass case. The closest thing that I've ever seen to something like this was when I was doing trauma surgery in Cook County, Chicago. I saw a young woman who was targeted by gang members. She was actually the partner of a gang member, and I guess people from the opposing gang actually had AR-15s and gunned her down on an overpass. And she had multiple gunshot wounds throughout her body. We took her straight to emergency operating room and performed an emergency C-section. It was in this style, like going a vertical incision straight down. And miraculously, no bullet wounds actually hit the baby, but there were injuries to her liver and spleen, and she required what we call a damage control laparotomy after the baby was delivered. So we essentially pack the abdomen with sponges to actually decrease the amount of bleeding, and vacuum seal the abdomen while it's open, send the patient back to the ICU, give them a bunch of different medications and blood products to actually stabilize the patient, and do repairs to all the internal organs in stages as like their blood pressure can allow. So that is probably the closest thing that I've ever seen to something like that. And honestly, that was seriously one of the craziest things that I've just ever been involved in. Well, first of all, I was kind of shocked that the gang members just gunned down a pregnant lady that was like full term. Yeah, it was absolutely wild. And I remember I was thinking about that case for months.
Where are you?
I'm at Adam's house. Okay, I'll call you tomorrow.
Tomorrow? Wait, are you spending the night?
His parents invited me.
They need to ask me that. Okay, can you have them call me as soon as they get home?
So technically, unless Mel is the legal guardian of her sister, the parents of her boyfriend don't necessarily need to call her or ask for consent for her sister to stay over. But I do agree that it probably is the right thing to do. Like, I think if I was the sibling of someone with a mental disability or a learning disorder, I would appreciate it if, you know, the parents of someone else were speaking with me so that, you know, I feel comfortable and safe that they're not going to be taken advantage of.
Can I help you?
Checking in on the status of someone we sent up here earlier.
So this is realistic. I actually do go up to the ICU from time to time just to check in on some of the, you know, cases that I've sent up. For me, it's really interesting just to see how patients are doing. And oftentimes when patients roll through the ER, they're not fully conscious or, you know, it's just such a chaotic environment that they can't really take in what's going on. So for me to actually connect with the patient after they've been stabilized in the ICU, I always feel like is always quite meaningful to my personal practice.
Oh, yeah. She's good. She's in 4202, recovering nicely.
Great.
Saved her life, even if we couldn't save her leg.
Oh, so her leg was amputated.
Was it below the knee?
Unfortunately, it was above.
Damn. So they did an above knee amputation. You have to do what you have to do to save a patient's life with necrotizing fasciitis. Ideally, we try to do the amputation below the knee because it gives you one extra joint of articulation where patients can have a prosthetic attached to it and live a pretty normal life. Oftentimes, like, I've actually seen some patients where they walk totally normally and I'm like assessing their legs and realize, oh, one of these legs is prosthetic, you know? They can live a pretty normal life if it's a below knee amputation, but with an above knee amputation, oftentimes they kind of walk with a limp or have to adjust their lifestyle because of it.
You can't do anything critical where a 5-second lapse in consciousness could potentially kill a patient.
But 90% of our patients don't require critical procedures.
And the ones that do?
Robbie, I can handle it.
No, you can't, and I can't let you.
If you were a patient, we would have to report you. I'm trying to protect you and my patient.
Oh, so that became super explosive, but I think Dr. Robbie did the right thing. She is not safe to drive. She is not safe to work in the ER. Yeah, it looks like she just didn't take that very well, but it is the correct call. It's the safest call for the patients, and patients always come first.
You want to know why I never killed myself? It can be unbearable and brutal and ugly and heartbreaking, but it's also beautiful.
Nothing will ever matter more than what I've done in this hospital, but it is killing me. And I've seen so many people die that I feel like it's leaching something from my soul.
Yeah, I feel that.
100%.
Yeah.
You gotta find somebody to help you dance through the darkness.
Did you just make that up?
Jack Abbott is totally right. The emergency department is as up as it is amazing. Like, it is so cool to work in the ER and just see the shit that we see all the time. But yeah, it definitely does impact you and kind of like changes your perspectives in so many different ways.
Did you find your ID badge?
No.
Skinny Pete.
Sodium gives you yellow.
Skinny Pete had his badge all along.
And barium is green. Who knew chemistry could be so damn pretty?
Hey.
Hey. I'm doing the work, and you're still riding me. How can any of us live up to your standards if you can't even do it?
Crazy.
What would have happened if I'd paralyzed that guy? You need help.
Dude, I feel like they kind of like teased this conversation between Dr. Robbie and Langdon throughout the entire season. And the way that this conversation went out, I think is perfect. With Langdon being the one to clearly tell him he's got issues, he needs help, he's seen people in rehab that are exactly like Robbie. That's so true. And I also really like how Langdon asked Dr. Robbie what would have happened to him if the guy that he did the cervical spine reduction on became paralyzed. Because it just really, it kind of comes back to what I was saying in the last review, that if things went sideways, that would have fallen onto Langdon. He would have been found at fault and 100% liable, because that is not within the wheelhouse of an emergency physician. So, you know, Dr. Robbie is clearly turning into a loose cannon, and he either does not have any insight, or he has insight and he's just not in a place to actually seek help, which is even just as dangerous.
I'll stay with her.
Thanks.
Bro. Is Dr. Robbie going to become the de facto dad for this baby Jane Doe?
Why are you crying? Why are you crying, little one? I got abandoned too. But I got through all of that. And so will you.
Oh shit. Wow. Crazy. I thought it was a perfect way to finish that season. A lot of you have mentioned in the comments that you want me to go back to season 1. I actually haven't seen season 1 of the Pitt yet. And so if you want to continue learning through my Pitt reactions, click that subscribe button and we'll keep the good times rolling. I'll see you in the next one.